and welcome to Persistent Post-Concussive Symptoms, 5 categories of causes and treatment. My name is Katie Pierce. I'm a staff physical therapist at Core Balance Therapy in Flagstaff, Arizona. I'm also a board member with the Brain Injury Alliance of Arizona. And just this spring, I was certified as a practitioner in Complete Concussion Management Institute's, or CCMI, concussion practitioner course. This is a 50-plus hour course that I'm going to be referencing during this presentation with Complete Concussion Management Institute's permission. Hello and welcome to Persistent Post-Concussive Symptoms, 5 categories of causes and treatment. This presentation is primarily intended for physical therapists, occupational therapists, and other healthcare providers who are providing post-concussive rehabilitation. I'm Katie Pierce. I'm a staff physical therapist at Core Balance Therapy in Flagstaff, Arizona. I'm also a board member for the Brain Injury Alliance of Arizona, and I've recently been certified through Complete Concussion Management Institute, or CCMI, with their practitioner certification course. I have CCMI's permission to share information, sort of a teaser from that certification course with you today. And the disclaimer is that in this relatively short presentation of mine that you attend does not qualify you as a certified post-concussive rehabilitation provider, but hopefully might support what you're already doing with your post-concussive patients and inspire you to learn more. Persistent post-concussive symptoms are commonly called post-concussive syndrome. That diagnosis is from the DSM-4, which really no longer exists. I like to call it persistent post-concussive symptoms. I think it has less baggage for patients. However, when I'm communicating with healthcare providers, like referring providers, I will use post-concussive syndrome because it's more commonly talked about in the field. Definition of persistent post-concussive symptoms, or PCS, in the Berlin Consensus Statement on Concussion in Sport, are any post-concussive symptoms that last more than 14 days in adults or over 30 days in kids. For the ICD-10, which is probably the classification that you're also using for diagnoses, are 3 or more of the following symptoms more than 30 days after the concussion. For rehab purposes, starting rehab at the 10 to 14 day mark for patients who still have symptoms can be phenomenally helpful, and we'll talk about why. But consider PCS if symptoms aren't resolved by 14 days and go ahead and get started. In this presentation, first I'm going to talk about how I educate my patients on post-concussive syndrome. There's a drawing that I learned from CCMI to use with every patient that helps them understand what's going on with them. Then we're going to talk about 5 main theories of cause for post-concussive syndrome. For each theory, we're going to talk about how or why it happens, how to test for it in your clinic without any fancy imaging or anything like that, and the rehab principles for treatment. And these 5 theories are blood flow abnormalities, metabolic, inflammatory, and hormonal issues, visual or inner ear vestibular issues, the neck, and psychological or stress-related issues. Let's talk about the drawing that I give to all patients with post-concussive syndrome to help them understand what's happening with them. This is the drawing I give to patients with post-concussive symptoms that have lasted more than 30 days. So here we have a nerve cell, or neuron, and what happens with the nerve cell is that when it gets information from other cells around it, when it gets a signal, it's going to pass this information along to other nerve cells. And the way it does that is that there are a bunch of molecules inside the nerve cell and a bunch of different molecules outside. When a signal comes into the nerve cell, this is in a normally functioning brain, these little channels open and allow some of the stuff that's inside the nerve cell to come out and some of the stuff that's outside the nerve cell to come in. In a concussion, this is happening on a huge scale. When the brain moves inside the skull, the nerve cells get stretched and sheared, and all these channels are all of a sudden pulled open. And when the channels are pulled open, all this stuff inside comes rushing out, and all the stuff outside comes rushing in. And that causes the nerve cell to think it has received a lot of signals, and it passes that information on to the other nerve cells. It gets excited. So basically what a concussion is it's millions of neurons, of nerve cells in the brain firing at once and being tricked to think that they've just gotten a signal. And this creates kind of an electrical storm. And this electrical storm are the very immediate symptoms of concussion, like loss of consciousness or staggering off the playing field if the concussion happened in sport. But pretty soon, within a few seconds to minutes, the brain cell, the electrical storm kind of calms down. But then what happens in the coming days is that the brain starts to use a lot of energy because of this electrical storm. So we're going to make a little graph here for our patients. This axis is ATP. ATP is the energy molecule of the brain. This axis is time. So over the next hours to days, the energy level, the ATP level in the brain really starts to drop. And this peak low is about 3 to 5 days after concussion. And during this time, symptoms are often quite intense. Headache, fogginess, irritability, feeling more emotional. And then the brain starts to recover and get back up to that starting level, its base level. Now, this typically occurs, this recovery of ATP, within 22 to 30 days. So here's the questions we'll pose to our patient. We'll say, now, if this typically occurs within 22 to 30 days, you're seeing me here at 6 months or 2 years or 4 years, like a young person I met earlier this spring. Why are you still having symptoms? And usually they'll say, I don't know. So what we say is there are 5 main reasons that can be causing your symptoms to last longer than 30 days into the subsequent months and even years. 1, is blood flow. And we can test for this by, at the very next visit, getting you on a walking test on a treadmill, and we're going to see if your body is moving blood well to get enough oxygen up to your brain. And if it's not, if we see that you're getting symptoms on the treadmill, we can actually have a treatment for that. The second reason that you might be having some symptoms would be either metabolic. It's actually 3 sub-reasons: inflammation, or hormonal reasons. Now, metabolic reasons refers to this ATP. This is a really rare reason why someone would still be having symptoms because, as we said, the research shows that the ATP levels in the brain recover by day 30. But there are 1 or 2 reasons why it could be driving post-concussive syndrome. And that is, 1, if a person got a second concussion, well, they were still in this lower energy phase, they would then start to go down again. This energy would drop and they would recover. But I'm going to draw another line on our graph. And this line marks cell death, which would be a more permanent loss of brain cells. And if you notice, with 1 concussion, no cell death occurs. But if the person hasn't recovered fully and a second hit or a second concussion happens, they can dip down into that cell death area and perhaps be left with permanent or even life-threatening injuries. And that's what you may have heard of called second impact syndrome. And that's why, in your case, we're so glad you didn't have a second concussion. So it's very unlikely that your symptoms from this 1 injury are due to metabolic reasons. If you had a second concussion after 30 days, had passed, you would go down, and luckily you would come right back up because you would have already recovered from the first. So multiple concussions really only cause cell death if they happen in a close period of time. Inflammation is something that really does affect a lot of people, and that's why we're going to give you the diet plan. And the diet plan is a brain recovery diet, and we're going to talk about that after this. The third reasons could be injury to the visual or eye systems, or the vestibular or inner ear systems. We're going to check for this on the very next visit after your concussion walking test. The fourth reason would be your neck. And this is so important because to cause a concussion, a blow to the head has to have 70 to 120 Gs of force. And a G is a measure of force. To give you perspective, the airbags in a vehicle deploy at about 60 Gs. So that's a really big force causing a concussion. A neck injury, though, only takes 4.5 Gs for a cervical strain. So every concussion includes some level of whiplash injury. Oftentimes, what started as post-concussive symptoms and whiplash symptoms have now just become whiplash symptoms. And whereas a concussion typically recovers in 30 days, a cervical strain and whiplash associated disorder can take months or even years to recover. So that's why we're going to take special care of your neck. Finally, psychological or stress-related reasons. Concussion is a trauma, and it's stressful. Folks who may have had pre-existing anxiety or depression are at higher risk for persistent post-concussive symptoms. And if there are things like PTSD, that's also going to make it harder to recover. So we've got ways to help you identify if the way you're thinking about your injury is affecting your recovery, and to help you with that as well. And this is the drawing we give to every post-concussive patient. You can gauge your patient based on their energy level and their attention to see if you want to give this full version or if you need to sort of give them a simplified version. Here's a finished version of the post-concussive syndrome drawing so that you can have a copy for yourself. I do like to do it in real time in front of the patient. Let's get into those 5 theories of cause for post-concussive syndrome. One would be blood flow abnormalities, or physiologic. We all know that post-concussive symptoms can flare with exertion. Some people will say they were doing okay, feeling better, until they went back to sport, or even until they had a day of school. And cognitive exertion, lots of thinking, can also flare those symptoms. And what's in common with physical and cognitive exertion is that it requires more blood flow, more oxygen to the brain. Leddy and his group at the University of Buffalo attribute this reduced cerebral blood flow to autonomic dysregulation. And there are some studies that support this as a possible theory for PCS. Meyer and colleagues tracked blood flow in various brain regions at a day, a week, and a month following concussion. It was a fairly small sample size, but they found the only differences in blood flow at 1 month were in those people who still had symptoms. We can test for this really easily in the clinic with the Buffalo concussion treadmill test. If the patient has an orthopedic injury or a condition such as POTS, postural orthostatic tachycardia syndrome, that makes it hard for them to tolerate upright exercise, then you can do a modified exertional test on a stationary cycle or a stepper. We're going to talk about in a bit how to run the Buffalo concussion treadmill test. There are good instructions online. If the patient passes the BCTT, the Buffalo test, then their post-concussive symptoms are really not likely to be due to altered blood flow. You can cross that first theory off the list, and then we're going to proceed to test the others. This is the FACES chart. And I always have the faces on the wall near the treadmill. The test is run by having a patient warm up at 2.5 miles per hour. for about 2 minutes. Have the patient wear a heart rate monitor. This really works a lot better than a pulse oximeter on the finger. And you're going to keep track of heart rate, and you're also going to keep track of the patient's rating of their overall condition. Before you start, you're going to ask the patient, on this FACES scale with 10, the worst you've ever felt, and 0, you feel great, what are your symptoms now? And what we're looking for in our patients with persistent post-concussive symptoms is a rise of 3 or more points on the FACES scale. Every minute, I'm going to increase the incline on the treadmill by 1%. You do need sort of a fancy treadmill for this test, one that goes all the way up to an incline of 15. If you're working with a high-level athlete and they do reach the incline of 15, you start increasing the speed on the belt by 0.4 miles per hour for each subsequent minute. 3 reasons to stop the Buffalo concussion treadmill test would be the person reaches max exertion on the Borg 6 through 20 scale, they reach their age-adjusted max heart rate, or, as I said, their symptoms increase 3 or more points. The treatment flows really naturally from the testing. You're going to design an exercise program for these patients. If they had a heart rate, that worsened their symptoms more than 3 points, you're going to take 80% of that heart rate, and that's what you're shooting for designing their exercise program. If this is a high-level athlete who's had symptoms more than a month and is trying to return to sport, go ahead and use 90% of the heart rate that worsened their symptoms by 3 or more points. And if it's someone with chronic fatigue syndrome or POTS, well, to be honest, chronic fatigue would probably be even less, but someone with POTS would be under 75% of their triggering heart rate. The research suggests that 20 to 30 minutes a day of this exercise under the heart rate you've determined, 5 to 6 days a week, is the best way to go about recovering blood flow function. If your patient failed the Buffalo concussion treadmill test, you're going to retake it in about 2 weeks to determine the new heart rate tolerance and go from there until they're able to reach their max exertion, and then they can work out as hard as they want without contact still. Theory 2 really has 3 parts. Metabolic would be decreased ATP production. We saw this in the drawing. It's really uncommon. This would be unless the patient had back-to-back concussions, or in some cases, it's someone who returned to sport too soon, or returned to a super stressful job without missing even a day of work. And in that case, you might, with some caution, we'll talk about this in a bit, prescribe a limited rest period. Inflammatory issues are really common in our modern society. It can be measured by C-reactive protein levels. Note that C-reactive protein levels being high can be any inflammation in the body. The person might have Crohn's or colitis. It can correlate with increased gut and brain inflammation. And that's what the literature is telling us about inflammation, is that we're going to try to get these patients' systemic inflammatory issues down. Finally, look into hormonal issues. Start to think about hormonal issues if your patient is actually having worsening symptoms after 6 months. They got better for a period of time, and then you're starting to see worsening depression, worsening anxiety, urinary bladder issues. And this could be a pituitary gland issue because it is vulnerable to physical injury, and it also ties in with inflammatory. How to test for these 2 things? Metabolic, we talked about when to suspect it. You'd treat with a period of rest. Cam, who teaches the CCMI provider course, was saying that in his years and years of treating post-concussive patients, he's prescribed a period of rest maybe 1 or 2 times, truly in someone who never even rested for half a day. For inflammatory issues, we're going to use the Brain Recovery Diet by Dr. Herkel. This could also be a diet such as paleo or keto, and you're going to ask the patient to try it for 2 to 4 weeks and see if their symptoms start to get better. There is a link here if you want to look up Dr. Herkel's Brain Recovery Diet. Hormonal, again, it would be those worsening symptoms, and you'd refer to the primary care physician or an endocrinologist for medical testing and treatment of exogenous hormones. It is interesting to keep in mind that up to 37% of folks who've had a concussion will go on to need exogenous pituitary hormones. The third theory of post-concussive syndrome would be the visual and vestibular combined theory. 70% of patients after concussion, as shown in a study by Master and colleagues in 2015, went on to have neurovisual disturbance, accommodative disorders, convergence insufficiency, saccadic dysfunction. Smooth pursuits isn't listed in there, but eye tracking is a common disorder as well. 46% of patients had more than one testable visual disorder. When we think of vestibular dysfunction, it can be central brain-related or peripheral in the vestibular apparatus. And that's really common after concussion. We hear dizziness, off balance, and motion sensitivity as some of the most commonly reported symptoms. Remember with these two systems, that the cervical spine is intimately involved. If there's a vestibular issue, the vestibular system is not going to like fluid flowing through the canals and going to be sensitive to movement, so it will reflexively tighten the neck muscles, and you'll see a lot of cervical involvement as well. The testing for visual vestibular issues is simply running the VOMS, the Vestibular Ocular Motor Screening Test. If you're not familiar with the VOMS, ask Google. You'll find all sorts of instructions and detailed examples of how to complete a VOMS. You're going to look at smooth pursuits, horizontal and vertical saccadic movements, near point convergence, where someone brings a convergence rule. I've taken a 30-centimeter ruler and placed a little hanging tag on it that the patient puts the ruler on their forehead and then pulls the tag in and tells me when they see a vertical line on the tag has gone double, and that's convergence. Accommodation, I'm just noticing, is not on this, but it should be part of your VOMS. So here's one I found online that doesn't use accommodation. And that is with a single eye tested at one time. Again, pulling that card towards you with the ruler held at your head. The clinician is blocking the eye. And when 14-point font becomes blurry is when that eye has lost the ability to accommodate. And abnormal on that is less than 10 centimeters. You're going to test each eye separately for accommodation in someone younger than 30 years old. If they're over 30 years old, do expect accommodation to be over 10 centimeters. You're going to measure the vestibular ocular reflex, both in horizontal and vertical. Again, look for specific instructions on how long and how far your target is. And the visual motion sensitivity test, also known as VOR cancellation, is where you have your patient standing or sitting on a rotating stool. And 1 cycle per second, they're going to turn their head with their thumbs and the background is going to move. Any of these tests are considered positive if any particular symptom that you recorded at baseline on a 0 to 10 scale goes up by 2 or more points. The rehabilitation for visual and vestibular issues flows right from your VOMS test. If there's an abnormality that you detect, such as abnormal eye movements, or again, if the symptoms go up more than 2 points, you're just going to look at what provoked it. And then what I always explain to patients is, lucky you, we're going to find what brings on your symptoms, and then you get to practice it. It's provocative rehab, and it works. If someone's bothered by smooth pursuits, you're going to practice smooth pursuits. Saccades, if you're not familiar with the King-Devic, that's an actual saccadic reading chart that's used as a sideline concussion test, particularly in athletes. And you can use the King-Devic test as a practice rehab. VOR, you're going to have them practice the VOR itself. Visual motion sensitivity, just like the test, that can turn into your treatment. If folks are bothered by, say, walking in a store with a patterned floor or a patterned carpet, guess what? They get to practice that. After a concussion I dealt with in 2010, I was particularly bothered by body movement. And knowing that practicing it would help me, I went over and over to the Flagstaff Aquaplex and I rode those water slides with the little kids until I no longer got dizzy. So you really want to encourage people to take on the challenge and get their system habituated to no longer making those symptoms. Binasal occlusion and tinted glasses are temporary compensations. They don't make the problem better, but they may help the person feel well enough to tolerate rehab. Feel free to look up binasal occlusion. It's where you're going to use some tape right on the inside of a pair of glasses that the person doesn't mind getting taped, and they may be able to tolerate more of their rehab with the binasal occlusion. Tinted glasses could be orange lenses for night driving, violet lenses for computer viewing, anything you'd find on a low vision website. And finally, accommodation and convergence difficulties. You're going to practice accommodation and convergence. Ramp and step exercises simply refers to ramping up how close the object is to their eye, or practicing steps, like moving beads on the Brock string. If you're seeing a pretty significant accommodation or convergence insufficiency, I really would refer the person to vision therapy. Neuro-optometrists and vision therapists are trained to rehab these issues and have a lot more training than we do as rehab therapists in that area. Next, as we explained in the drawing to our patient, neck involvement can be huge. One of the real take-home messages I got from the CCMI provider course was that if you have a patient who years out has been everywhere and tried everything and is still having post-concussive symptoms, maybe they've already gone to vision therapy, they've had their head under a scanner, it was a negative MRI, think about their neck. Because again, every concussion includes a whiplash injury. And get to know the muscle and joint referral patterns. Trigger points or tender points at the SCM can cause a temporal headache, for example. And we're going to talk about how you check for this in just a bit. Keep in mind the cervical ocular reflex, the vestibulospinal reflex, and the cervical cortical reflex. These are 3 neck reflexes that communicate with the eyes and ears. And literally, you can get someone whose vestibular screening is positive, for example, on the VOR, but when you look at their neck, you replicate their familiar dizziness with neck movement only, and we'll talk about how to do that in just a minute. And then you might be realizing that what got them during the VOR wasn't the fluid moving in their canals, in the vestibular apparatus, but rather the neck movement. How do we test for cervical spine dysfunction? You want to keep the visual and vestibular systems still and move the neck. My first favorite way to do that is the smooth pursuit neck torsion test. This was new to me this spring in my training with CCMI. You'll have someone trace an H pattern, smooth pursuits, first with their neck forward, then with their neck turned 45 degrees to one direction, and then with their neck turned 45 degrees to the other direction. And you will literally see that someone with their neck forward has a good quality smooth pursuit. And then when I ask him or her to turn their head, I'll see saccadic jumps in the smooth pursuit. And the patient will say, those are my exact symptoms. And you say, congratulations, we've found it. Your cervical ocular reflex is not working well, because when we put your SCM muscle on stretch, it sends wonky signals to your eyes. The head-neck differentiation test is really easy. I have a patient sit on a rotating stool and I say, don't worry, I'm not going to spin you. You're in control. I'm going to hold his or her head still. And there is one difference, one big difference between this photo, is I actually always hold the patient's head from the front so I can look for abnormal eye movements. I don't stand behind them like the guy in this photo is. You're going to have the patient rotate at 1 beat per second, rotating their body on their head. So this is bottom on top neck rotation. And if they're replicating familiar headache, familiar dizziness, familiar nausea, then you're highly suspicious of the neck. How to treat it? Again, find what tested positive and practice it. We want to incorporate C-spine awareness into our oculomotor and vestibular rehab. Walking with head turns counts as cervical spine rehab. Keep in mind, this was a new learning for me as well this spring, that usually the muscle that is stretched, the muscles that are stretched when the neck is turned, are the ones causing the symptoms. And that's because the Golgi tendon organs and the high amount of proprioceptors in that muscle is getting disturbed with the stretch. So someone's walking down the hallway, you have her walk with head turns right, head turns left. She always loses her balance to the left. Think of manual therapy for the right SCM, which is stretched to the left superior oblique, and the right inferior oblique. This 5th category of post-concussive symptoms relates to every single patient who's had a concussion. And I really consider it part of my job to destigmatize the stress and the trauma related to concussion. Here's some things to think about with psychological aspects of post-concussive syndrome. One is this idea of default mode interference. We have a couple different modes in the brain. The default mode is when I'm sitting on my couch, watching Netflix, just chilling. Maybe I'm laying in the hammock and I'm just having that internal monologue go. I don't have to focus on anything in particular. Executive mode, on the other hand, is how I am right now in the presentation. I'm thinking, I'm staying alert. It's how you hopefully are watching this presentation. If you're in default mode, hello, wake up, thank you. What'll happen after a concussion is the default mode sort of becomes the norm because it takes more energy to get into executive mode. And this is the patient who says to me, I'm really worried about my brain because I drove home from Safeway yesterday and I swear I cannot tell you how I got there. All of a sudden I realized I was at my house. And I can say, oh, don't worry, that's default mode interference. You didn't forget where you lived. That's not a true cognitive problem. You checked out for a little bit. We all do that. And by practicing your focus, you'll be able to get over that. The good old days bias refers to patients with post-concussive syndrome tend to rate their pre-concussion baseline symptoms as better than the average population. If you look at the post-concussive symptom scale that's used by the IMPACT neurocognitive test, this is the symptom scale that's widely available online. Healthy control people who've never had a concussion will endorse 16 to 17 points of symptoms. And that's because on any given day, someone without a concussion could be feeling more emotional, they could be feeling irritable. And it's so important, that patients realize that everything they're feeling isn't due to the concussion. It might be part of the normal ups and downs of daily life. And that brings us to this third big area of psychological symptoms, and that's over-attribution of symptoms. If I misplace my cell phone, I think, oh gosh, I must not have been paying attention. Where did I put that? But someone with a concussion or someone with persistent symptoms after a concussion will often attribute every mistake or every weakness that they show as, oh no, I can never do anything right since that concussion. I'm always losing things. And it's so important that we help our patients realize that if we just step back and realize that mistakes are normal and maybe not due to the concussion itself, helps us relax a little bit and not attribute everything that happens to our concussion. That said, the way we identify these factors as contributing are we look for those three things. Look for default mode interference. That's the story about I don't know how I got home. Look for the good old days bias. This is someone who says, life was awesome before my concussion and now I'm just a mess. If there's a lot of comparison going on, you might want to bring that up. Tell them that it's a thing, it has a name. Up here at the top, just being aware that patients with pre-existing depression and anxiety are 5 times more likely to develop post-concussive syndrome. Even having a family history without a personal history makes someone 2.5 times more likely to develop post-concussive syndrome. Knowing this can help the patient realize there's a reason for it. They can seek counseling, they can get help, and remind patients that we all make mistakes. I think it's important for me as a provider and also as a concussion survivor that if someone's telling me there's something they're upset about related to their concussion, I'm not going to go straight to, everyone makes mistakes. That's not really what they want to hear. First, I might give some empathy and say, yeah, it sounds like things are really tough right now. You're really wanting help for these symptoms that are really bothering you. And I think I have a way of framing it that might help put your mind at ease. And this is something called the good old days bias or the default mode interference. People really appreciate, first, I've connected with them on a place of empathy. And second, I've given them a tool to realize what's happening. Refer these patients, give them education and reassurance. Symptoms have a cause and we have a plan. It's really neat because in the complete concussion management course I took, Cam was talking about how with the whiteboard drawing that we give to patients, they'll sometimes come back for their second visit and their post-concussive symptom score is 50% or less of what it was. I had a young person this spring who'd been dealing with symptoms for 4 years. and I educated them and their parent about these 5 causes of post-concussive symptoms, did the drawing. This person's score of symptoms was a 70 on the post-concussive symptom scale. They came back a week later and their score was a 14. And so to know that I'm in the right place and that a provider gets me and has a plan to address my symptoms, this is invaluable. If you get good at one thing and one thing only, educate and reassure your patients. If anxiety, depression, or OCD type behaviors are really getting in the way, talk to the person's family doc. Have them go look at a course of short-term medical management. Supportive counselors, specific trauma recovery methods. I dealt with PTSD after a bicycle accident in 2008, and the EMDR specific method with a counselor of rewiring my brain after trauma completely wiped out my flashbacks, and it gave me my life back. Also, when patients are really worrying about their brain, thinking they have memory and cognitive impairments, refer to a neuropsychologist. This is someone who can give a full 4-hour assessment and help the person know if their symptoms really are driven by cognitive impairment, or if in many cases they're actually testing out okay for their age and gender and education level. And that's someone who's going to come back very reassured. What should we keep in mind for the timeline for these patients? Keep in mind that for sub-symptom threshold aerobic exercise, if someone's really exercising 5 to 6 days a week for that 30 minutes a day, they're going to start feeling better in 2 weeks. You're going to retest at a higher heart rate on the Buffalo concussion treadmill test. Within a month and a half, they're probably going to pass that thing. And you can cross blood flow off the list. To test the brain healing diet for inflammation reduction, the person really needs to be strict for 2 to 4 weeks. No gluten, no dairy, no starches or refined sugars. And part of that, it's going to reduce their caloric intake, and it's going to help really put vitamin, mineral-rich fruits and vegetables and pasture-raised meats into their diet. Some patients will even be interested in a referral to a naturopath, and that's a great idea. Other patients may have a lot of trouble with even the idea of changing their diet, and so I'll let them know it's out there, but we'll focus on the other 4 pillars for a while. Vestibular issues, if the person is practicing 3 times a day religiously for a minimum of 2 minutes at a time, it's amazing. They come back 2 weeks later, they perform the smooth pursuit neck torsion test for you, and their eye movements are normal, and that is so cool to see. In other folks who've had symptoms for longer, might not be as adherent, you're looking at 4 to 8 weeks. My typical plan of care for someone who needs a lot of neck work is 1 to 2 visits a week for 4 to 6 weeks, and you should see a lot of change. So this can be really reassuring for patients. I will write down their physical therapy goals, give them to them on a handout and say, put this on your fridge, put it on your bathroom mirror, put it on your desk, because you doing the work is going to get you here. Now here's my plug for Complete Concussion Management Institute. This 50-hour plus training course will not only take care of all your CEUs for the entire next period, but I learned so much that I didn't even expect, that I didn't know about concussion. So it's a really great course. I want to thank the Brain Injury Alliance of Arizona for helping me put together the filming for today, and that I can offer this for the virtual conference. Thanks to Complete Concussion Management for giving permission to allow me to share information from this course. And thanks to Core Balance Therapy, where I work in Flagstaff. My bosses have stuck with me since the days when my post-concussive symptoms were keeping me from being the healthcare provider I wanted to be, all the way through now when I'm a post-concussive specialist and feeling great. If you have any questions, feel free to contact me at Katie, Katie, at corebalancetherapy.com. Or if you're attending the live version, I'll be here to help you answer questions live. Thank you.